The fictitious but very relatable Somewhere Regional Emergency Care Council, also known as the SREC, has an executive leadership committee consisting of top executives from each of the region's emergency care provider organizations, the major payers, patient advocates, as well as a couple of local elected and senior appointed officials who represent the city and county governments in the region. SREC is the mechanism by which all of these players work together to address the emergency healthcare needs of their region, and this executive leadership committee provides high-level direction, support, funding, and a point of accountability for SREC's clinical and operational committees. Now, each of the emergency care provider organizations have their own internal measures and reports or dashboards to guide their respective management decisions and quality improvement efforts. But collectively, they don't have a good way to objectively measure how well their emergency healthcare system is operating so that they can make sound data-driven decisions about where and how to focus their efforts and resources to improve system quality and efficiency. These leaders believe in the idea that you can't effectively manage what you can't effectively measure. So, with that in mind, the Executive Leadership Committee has put together a data committee to work with the various clinical committees to develop a set of regional measures and a regional dashboard that will allow everyone to track and see how well the regional emergency care system as a whole is performing. So, as you can imagine, this project is going to require processes to not just collect data from the various emergency care provider organizations. Those data also need to be appropriately combined or aggregated to calculate the desired system-level measures of performance. Today's webinar is going to identify some of the challenges in data aggregation across individual and multiple case types in provider organizations.
Hi, everyone. On behalf of the American College of Cardiology and the Center for Systems Improvement, I'd like to welcome you to the EMS and Systems of Care webinar series, Taking Clinical Quality to the Next Level. Our co-moderator for these webinars, Tim Phelan, is unavailable to join us today. For those of you who don't know me, my name's Tom Bouthillet, Program Implementation Manager with RQI Partners, which is a company that is owned by the American Heart Association in Laerdal. Until recently, June 30th of this year, I was EMS Battalion Chief with Hilton Head Island Fire Rescue. If you're watching this webinar live, feel free to use the chat window at any time. This will allow you to make comments and communicate with us and the other participants, even before we get to the question and answer portion of the webinar. This has become a perfectly acceptable and encouraged online conference etiquette. If something resonates with you, make a comment in the chat. If something comes up that you have an issue with, again, make a comment in the chat. Other attendees can respond back and we might jump in as well, or we may save our response for chat items during the Q&A portion of the webinar.
So the other way you can provide some feedback and interact with us during the sessions is using the emoji tool at the bottom of the screen. And when you do that, the emojis will float up across the screen and give us a sense of how you're reacting to the content. You'll also be able to enter questions as we go along into the Q&A tab. That's over on the right side of your browser window. And there's also a feature where if you click the raise hand icon, you can actually join us on the digital stage with your webcam and microphone, and we'll allow you to present your question in that manner.
If you're watching the archive recording of this webinar, please feel free to send in questions and comments directly to Mick at mic@improvethesystem.com. The archive recording will be posted soon after the live session with an email notice and viewing link sent out to everyone who registered for the event. Mick will do his best to respond to questions and comments sent in by email, regardless of how long it's been after the live event that you might be watching this. The main content for today's webinar will be presented by Mic Gunderson, President at Center for Systems Improvement. CSI works with the ACC on EMS and systems of care related products and services. I'll now turn the presentation over to Mick.
Thanks, Tom. Appreciate you being here doing moderator duty for us. We're going to go ahead and get right into the main part of the presentation, so stand by for just a moment while we bring up that portion of the program. This EMS and Systems of Care webinar series is supported by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. A new tool is on the way from the NCDR to support EMS and Systems of Care efforts to improve STEMI care, and it's called NCDR eReports EMS. More information on this new tool is available at acc.org/eReportsEMS. And if you'd like to watch any of the prior webinars from this series, descriptions and links are available again at acc.org/eReportsEMS. Just scroll down to the resources section of the page and click the View Series bar to see the full listing of prior webinars and links to register for upcoming webinars in this series. I hope those of you attending this webinar live took advantage of the lounge while waiting for the presentation to begin. If not, we will have it open for the 30 minutes following the presentation until about 3:30 p.m. Eastern. I hope to have a chance to meet you there at one of the tables. And this is a pretty interesting feature of our meeting platform that's designed to help you connect and network with colleagues that share an interest in EMS, time-sensitive systems of care, and quality management. You can move freely from table to strike up or join conversations, just like at a real face-to-face conference. So just click on any of the tables in the lounge and join a conversation. As soon as there is more than one person at a table, it turns into a video chat for the people just at that table. When someone joins your table, say hello and introduce yourself. This is a great way to meet some new people and expand your professional network. So let's get into the core material for this presentation, and we'll come back live on the other side for your questions and comments. Please use the chat window to make comments and talk to your colleagues as we go through the material and enter questions into the Questions tab as well for the QA section later on in the webinar. So today's topic is data aggregation. The scenario from the opening of the webinar has many of the same challenges we all face when we try to combine or aggregate data internally or with other organizations that are part of the continuum of care. The regional dashboard system that the fictitious Somewhere Regional Emergency Care Council, or SREC, wants to put in place has some political, operational, and financial challenges, but today's webinar is going to focus on the more technical issues in data aggregation. So let's suppose we want to combine data on a single case, a single patient for a single episode of care. And there'll usually be several data sources for that case. We'll have the 911 dispatch center's computer-aided dispatch or CAD data. And it'll have the times when the call was received, which units were sent on the call, and when the responding units were each notified, started on their way, and when they arrived at the address. It might also include information on the telephone triage process for the type of call, its severity category, and any pre-arrival bystander or patient self-care instructions that were given. The non-transport medical first response unit, which is often some sort of fire truck or utility vehicle, will have an electronic patient care report as well. The ambulance has one too. So moving further along the continuum of care, we can have an electronic medical record from the hospital. And sometimes the emergency department team or an acute care intervention team like a trauma, stroke, or cath lab team may have their own electronic medical record system. And this will further complicate our efforts to aggregate data. And if we're trying to be thorough, we would also want to look at the post-acute phases of care to include rehabilitation and secondary prevention as we try to prevent a repeat of the STEMI, stroke, trauma, or other specific problem. And we've talked so far just about the direct clinical data, but depending on what we were trying to measure, we might want to bring in data for that case from the online medical consultation record system. Any quality management program information from the cases might be generated from an incident report or a quality review audit, or more routine reviews like those using the data files from a monitored defibrillator to generate information about resuscitation quality metrics like compression fractions and perishock pauses. We might want billing data, We might want data from law enforcement if it was a motor vehicle crash or criminal incident. We might also want data from the coroner's office or death certificate if the patient died, and we want autopsy information and the stated cause of death. So for one patient with one specific episode of care, we can end up with a lot of different data sources. And despite the fact that it would be wonderful to have all of this information aggregated together to look at for the overall episode of care, we don't see that happening very often because it can get extremely difficult to do. And often, the more formidable barriers to getting this sort of aggregation done can be political. Agencies may be reluctant to share data with others out of fear that the data will be used in some way that could embarrass them or give them what might be seen as proprietary information to competitors. That's a different topic, but let me just say that the design and membership of the fictitious Somewhere Regional Emergency Care Council is based in the reality that both clinical and non-clinical stakeholder representatives need to come together with a unified purpose of improving the system of care. The non-clinical stakeholders, particularly the payers and the high-level representatives from local government above the level of the EMS, fire, and 911 chiefs, can bring financial and political factors to bear that can align everyone's incentives to do the right thing for patients and the community in ways that will usually not happen without those influences. So for this example, let's assume that the SHRAC has been able to get all of the stakeholder organizations on board with the idea of aggregating data across their organizations by putting in policies that help prevent the data from being used in a negative way to embarrass participating organizations or compromise their competitive interests. The challenges then shift to the technical ones, and this is where I'm going to focus. The most basic way to aggregate the data is manually or semi-manually. This might not be practical with large case volumes, but is very doable on higher risk, low frequency case types like cardiac arrest, STEMI, stroke, and major trauma. And a great example of this is found for out-of-hospital cardiac arrest cases through use of the CARES registry, and a tip of the hat to Program Director Dr. Ryan McNally and the rest of the team at Emory University for their wonderful process design. When an out-of-hospital cardiac arrest resuscitation takes place by a crew in a CARES participating EMS agency, the CARES coordinator at that EMS agency will enter a specific set of data elements into the CARE registry's web-based data entry screens. Commonly, the CARES coordinator at the EMS agency will periodically run a report to identify EPCR records for cardiac arrest cases, and those are the cases that they'll enter into the registry. After they look at the case and confirm it's appropriate for entry into CARES, they will use a data entry screen for CARES alongside a window for viewing the cardiac arrest cases from the EPCR system. They can then refer back and forth between those two records as needed to get the data elements typed into CARES. This process is called manual data abstraction. And efforts are underway in many places to get this process more automated by having the EPCR system software identify the cardiac arrest cases and then automating the data entry of the appropriate data fields into CARES, ideally with some sort of a QA check to make sure everything is appropriate and correct. Now, the EMS part of the process typically uses the ambulance EPCR. And the ambulance EPCR record usually has some aggregations built into its design. It usually includes some information that was originally corrected by the 911 center, such as the time the call was received and dispatched. It often includes some non-transport medical first response information, as well as when crews arrived before the ambulance, when CPR was started, and when other interventions may have been made by that first-in unit. If a patient was taken to the hospital identifier field is also entered. So, after EMS completes its part of the data entry for that case by the CARES coordinator, the hospital identifier field is used by the server to find the email address of the CARES coordinator at the hospital that received the patient. That hospital cares coordinator is sent an automated email to notify them that a resuscitation case that was taken to their hospital was entered into the cares registry by EMS. So now the hospital cares coordinator can then monitor that case until their discharge, regardless of their outcome. They'll look at the hospital's electronic medical record and then manually enter the requested data fields into the cares registry, also using manual data abstraction. The good part about this process is it's great at connecting an EMS data set on a cardiac arrest case to the appropriate hospital data set, because the EMS cares coordinator and the hospital cares coordinators are entering data into the same clinical registry database. The EMS record part has the patient name, date of birth, times, EMS unit numbers, and other fields that make it easy for the hospital cares coordinator to make sure that they're entering the correct hospital record that's most likely to be the same patient episode of care. And this is called manual probabilistic matching. Same or similar name, same EMS unit, same time frame, etc. And without a name or date of birth, the matching is less certain, but still works pretty well, mostly because even in busy hospitals, it's unlikely the two cardiac arrests will come in via the same ambulance service in the same time frame and with the same patient demographics in general. Now, some communities take this whole process up a big notch to virtually eliminate any confusion by using deterministic matching. In EMS to hospital processes, this usually involves the use of a universal patient identifier system. And as an example of that, the Southwest Texas Regional Emergency Advisory Council, or STRAC, which serves the region in and around San Antonio, Texas, works with all of the EMS agencies and hospitals in their region, and they put a universal patient identifier program into place. EMS puts a numbered wristband on all their patients, and it stays on the patient through their entire episode of care. EMS puts that wristband number, the universal patient identifier number, into the EPCR, and hospitals also enter it into their electronic medical record system. That allows the EMS to hospital record linkage to be determined with extreme certainty by the matching of the universal patient identifier numbers across the separate record systems. This is much more reliable than probabilistic matching, especially when the patient name, DOB, or other information is not available. It also makes it much easier to automate the processes for matching records from the different data sources, so long as that universal patient identifier number is entered correctly into each record. So this process has many advantages, but please take note that this was made possible by the fact that, like our fictitious Somewhere Regional Emergency Care Council, the real-world STRAC in the San Antonio region of Texas has broad stakeholder representation and support from the EMS agencies and hospitals. The STRAC provided a venue where EMS agencies and hospitals can effectively collaborate on issues at a systems level and make operational decisions to do things like this. So a tip of the hat also goes to Eric Epley, Dudley Waite, and the rest of the STRAC team and the participating EMS agencies and hospitals in the San Antonio region for pulling together to put a universal patient identifier system into place. But there's other ways to aggregate data apart from what's been described so far. One of the tools used when trying to automate the record matching is called middleware. Think of it as a software system that sits in the middle between the data sources. The middleware then uses probabilistic and/or deterministic matching algorithms to link records from one data source to another. That then allows reports to be run using specific data elements from the different record systems for a particular episode of care. This middleware approach is typically used with health information exchanges, also referred to as HIEs. The HIEs can go one step further by actually pulling some specific data elements out of each data source associated with a particular episode of care to create its own episode of care record within the HIE data system. And by storing a subset of key data elements inside the HIE that were taken from those multiple data sources, searches and reports can run much faster. One of the issues to address in manual or automated data aggregation is not just collecting and connecting the data, but making sure that the data uses consistent definitions and formats. We need to make sure that the way one organization defines a STEMI, for example, or a suspected STEMI, is the same as how others do. We also want to make sure that the way the data element is formatted is consistent across organizations and data systems. So we don't want to mix all acute myocardial infarctions from one data source with just STEMIs from another data source if we're trying to just look at STEMIs. We also want the data code for STEMI from one source to be the same as used in the other data source. If a STEMI case from the medical record system in Hospital A stores the information that indicates a STEMI with a code of XYZ123, and Hospital B stores STEMIs with a code of ABC789, that'll create an issue. Same goes for the way EMS agencies store and code their data elements. Now, fortunately, most every EMS agency in the United States uses the National EMS Information System, or NEMSIS standards, for how cases and data elements are defined and how the information gets coded into their EPCR record system. In developing the NEMSIS data standards for EMS, steps were taken to base those EMS definitions, codes, and formats as much as possible on those used by hospitals and other healthcare provider organizations. This standardization across standards is called harmonization. Harmonization between EMS data standards and other healthcare data standards helps in a huge way by allowing data to move back and forth between EMS and hospitals when trying to do these sorts of aggregations. But a lot of what I've been talking about with standardization of data definitions and formats takes place between professional societies at a national level or even international level. So let's bring our discussion back closer to home for an EMS quality manager or a hospital STEMI stroke or trauma coordinator. So here's another process design to consider. An EMS regulatory agency in Michigan put a different type of process into place for aggregating EMS and hospital STEMI records so that it could calculate and report on how well their STEMI system of care was working. Each of the system's 3 ambulance service QI managers were asked to populate a standardized Excel file each month with the cases that their crews coded for STEMI. The standardized Excel files had a set of columns for each of the data elements that each ambulance service needed to populate with data from the eligible cases. Each separate case had its own row in the Excel file, and there was a similar Excel file populated by each of the 3 hospitals in the region that did emergency cardiac catheterizations. So right after the end of the month, the EMS QI managers would sort their Excel file by destination hospital and securely send the appropriate subset of cases to the appropriate hospital. Each hospital STEMI coordinator could then look at the EMS data in the Excel files to do manual probabilistic matching between the EMS and hospital cases, and they'd cut and paste their hospital data elements into the appropriate row of the EMS Excel file. With 3 ambulance services, each hospital received 3 Excel files every month, one for each EMS agency. They also had another Excel file, and this is where they put cases that they could not match with an EMS case. The hospitals would then send back their completed files to each of the EMS QI managers respectively. So they'd get together then on a conference call or a face-to-face meeting after all of that. The 3 EMS QI managers and the 3 hospital STEMI coordinators would get together equipped with their laptops that were connected to respective medical record systems and resolve any cases that had missing information. Perhaps an EMS record that did not have a destination hospital filled in, but was transported. Perhaps a patient that arrived by ambulance, but did not have an EMS agency identifier. All of that sort of thing got sorted out, and the cases were filled in with the requested data fields. At the end, the regulatory agency had a master data file for the entire system of all the actual and suspected STEMI cases, and each of the ambulance services and each of the hospitals had their own files with robust data from both EMS and hospitals for all actual and suspected STEMI cases that their organizations treated. Performance measures could then be calculated at a system level as well as for each ambulance service and each hospital. Now, there were around 30 STEMIs a month in that system, so the case volume made this practical to use. But it's something to keep in mind if that could work for your agency and the resources it has available. Here's another one to consider. An EMS system in Florida used to run its own registries for cardiac arrests, drowning, STEMIs, major trauma, and advanced airways. To get complete and timely data from the non-transport ALS fire rescue crews, the ambulance service, and the hospitals, the medical director's office had a designated medical communications officer, or MCO, in the 911 communications center 24/7 to manage the radio patches from field crews to the on-call online medical control staff and to the hospital ED radios. But they also had another responsibility. The MCOs would call EMS crews at the ED to verbally interview them when they had a patient that fit a category that was tracked by any of their registries. And during that telephone interview process, the MCO would ask for specific times and other information, which they would then type directly into a data entry screen on a PC. On cases where it was needed, the MCO would also talk to the ED staff and do a similar debrief to get data elements. So within a short period of time after patient arrival, the medical director's office had most of the data aggregated in their computer database for all of their registries. The MCOs would also do follow-up calls to the hospital to get discharge status information several days later on things like survival to discharge, neurostatus, etc. And once everyone in the field and the hospitals got used to it, the process flowed very well and generated incredible reports that fueled excellent QI projects. So we've touched on manual and automated or semi-automated data abstraction. We've covered probabilistic and deterministic matching, and we've covered a couple of different processes for aggregating data on the same patient episode of care across EMS and hospitals. So let's consider another data aggregation scenario with aggregation across different types of cases. For example, suppose that the Somewhere Regional Emergency Care Committee wants to create a composite measure for how well their system of care is working for time-sensitive cases overall, perhaps including cardiac arrests, STEMIs, strokes, sepsis, and major trauma. We did a webinar on composite measures a while back, but with regard to the data aggregation challenge of doing this, I just wanted to point out that you may want to consider normalizing the data based on case volume. Let's assume for this example that we have a composite metric in place that gives us a single overall score on how well the STEMIs were cared for in a given month, and that we had a similar single score that reflects on the care for the other case types as well. So we end up with an overall score for STEMI, one for stroke, one for major trauma, and so on. And we want to aggregate these into a single overall time-sensitive care score. So let's also assume for this example that the Somewhere Regional Emergency Care Committee puts the same level of importance on all of the time-sensitive care case types they're tracking. But there are very different case volumes for each of these case types. So as you aggregate the scores together, you may want to normalize the scores based on the volume. What that means is that if you have twice as many major traumas as you have cardiac arrests, the major trauma score would have twice the influence on the overall time-sensitive care score than the cardiac arrest scores would. Now, I'm going to refer you back to the Composite Measures webinar for more detail, but I think it's important that you be aware of the issues in data aggregation, not just for individual cases or on cases of the same type, but also on cases of different types that may want to be aggregated. So that'll wrap up the formal presentation portion of the webinar. Let's go back to the live broadcast for your comments, questions, and get some answers. All right.
That was really good, Mick. As someone that has logged many hundreds of cases into the CARES registry and pulled data from multiple sources, including CAD, but then had aspirational goals for including telecommunicator CPR metrics directly into CARES, and getting more robust outcomes from the hospital for other diagnoses. Why are we still having difficulty here? What didn't the federal government start asking for healthcare interoperability in the 1980s?
Yeah, that was the whole idea, but yeah, I'm very confused by it. On the EMS side, I think we've done a great job because we've all kind of standardized on NEMSIS, and there's a certification process that verifies on behalf of the purchaser that a given platform is NEMSIS compliant, and they pretty much restrict the data entry to that data dictionary associated with NEMSIS. But on the hospital side, there's a whole lot more diversity in how their HL7 defined data elements are entered and how they're formatted. And I've heard many people make comments, kind of like we have in EMS, where when you've seen an EMS system, you've seen one EMS system. Well, that kind of translates on the hospital side when you've seen like one Epic installation for a medical record system at a hospital. You've seen one Epic installation, meaning that they're all very, very different, even though it's still Epic or Cerner or whatever the particular platform may be. And it's probably partly due to the fact that the hospitals have a lot more data to deal with for a multi-day complicated course of care than EMS does for 30, 60, couple hours at most during our little piece of the episode of care. But yeah, I always thought we'd be a whole lot farther along on this than what we are. And I think some of it tracks back to the proprietary interests of some of the software vendors, certainly, because they want to keep you in their ecosystem. And so the hope I'm kind of holding out is as we start seeing a shift from pay for service or fee for service reimbursement strategies and shift more towards these so-called alternative payment models under ACOs and organizations of that sort. We're going to see the payers insisting on getting this mess straightened out, because it's the payers who are taking the hit financially for these inefficiencies and being able to quantify not only the quality of care, but the cost of care, and then combining those two together to get, a value metric on a given episode of care. And so I'm hoping that as that begins to happen, the financial incentives for getting past these proprietary issues will go away. But I'm an optimist, but reality sometimes doesn't align with my optimism.
Yeah, true. But honestly, you would think that, let's leave the hospital out of it for a second. Not that I want to let them off the hook, not that I want to let the PCR vendors off the hook for charging exorbitant fees for allowing two-way data, okay, to where you can get the outcomes. The reality is that even getting the EMS record into the patient's chart is a challenge in 2021. Much harder than it used to be when you just filled it out with a pen and pulled off the pink copy or whatever it was and laid it in a little bin and they just scanned it into the system. It seems like the more you would think that interoperability should be happening, where you just hit a button and it automatically goes directly into the patient's record, not into a little sequestered spot where with like 20 mouse clicks you can theoretically pull up a PDF, but like integrated into the hospital's data, and then that diagnose coming back the other direction. We ought to be able to figure that out. But let's leave that out of the conversation for a second, because
Okay.
anyone that's ever wanted to do a really good job putting data into the CARES registry and wanted to double check everything from the initial rhythm to verify that it was shockable or non-shockable, to the CAD data to see what time the call came in, when the first unit responded, but also when all the other units responded, that wanted to know what was the dispatcher's performance that day. Did we hit our benchmarks with telecommunicator CPR? How many screens do I already have open in front of me? Because I had 3 computer screens, and even if you cut them in half and turn it into 6, I know for a fact that you can fill up every single one of those computer screens just with internal data from your own EMS system, multiple passwords, just to give yourself enough situational awareness to understand how your system performed that day. And don't we deserve an EMS leaders, some kind of push button integration where all of those data sources can come into a one-pager for a time-sensitive diagnosis as important as sudden cardiac arrest?
Yeah, I think this is where I think there's an opportunity for a middleware player to come in and do those sorts of things. I haven't seen that in the market yet. As I read healthcare technology journals, I see lots of ads for companies that claim to do a lot of integration from disparate data sources. But the reality that I see, you know, as I visit clients around the country, doesn't really line up with that. There's certainly been some progress made, but I haven't seen that same sort of progress made on the EMS side with those sorts of integrations. What I've seen happening is those big dominant players in the hospital medical records space trying to have a larger and larger footprint so that, you know, within their respective medical records ecosystems, if you will, they can bring that data together, but it has to be part of their ecosystem, and to interface into that, you know, as a different company is where the problems seem to arise. And that's why I think, you know, when I do the root cause analysis, if you will, on this, it kind of comes back to the old Tom Cruise phrase of follow the money, or maybe that was Cuba Gooding Jr. I forget which one, but anyway, if you look at the financial incentives to make this stuff happen, they aren't necessarily aligned with the operational needs at the end of the day, unfortunately.
Okay, so then I'm going to ask a provocative question. Why do we assume that it's the free market's job to take care of this? For something this important that affects every member of society, why isn't there some kind of open source, non-proprietary framework that, just like when you go to the store, when you go to Lowe's and you buy a toaster or whatever, you bring it home, it plugs into your existing electrical system in your house. The plug is compatible with your electrical system at home because we have an electrical code that, you know, so unlike our phones, I guess there's my own argument out the window. When we allow industry to have their own special proprietary connection, then everyone's trying to force you into their own ecosystem. But what we're talking about is multiple data systems that is producing one thing, and that is like a highly understandable graphic and maybe representation of system performance. You want, as you said, you want your CAD data, not just for the transporting ambulance, but for every apparatus that responded. You want your TCPR performance measures. From the PCR, you need the patient's name, the age, the gender, the medical history, the narrative, and you're going to try and discern the answer to all those CARES questions. You need your defibrillator case download data so you can verify whether or not the initial rhythm was shockable, that you can identify pauses, not just the peri-shock pause, but how long did it take me to put on that Lucas device? How long did I pause for airway management? In a perfect world, all of these data sources would be available for you to be able to put that case into CARES properly. And that's someone with expert level knowledge of the CARES data dictionary and everything like that. So getting to the question that you and I were discussing in the chat of why the CARES registry prefers more curated data is because they know from experience the raw data from the PCR usually isn't that great.
Yeah. No, I agree. I agree, and I think it's going to be, more of an issue for the user community to rise up and start demanding this from our suppliers. And this is where I would really like to see our professional associations take a stronger role, and start, maybe with some of the simple stuff, with, making sure that cables are compatible. Something, specific to cardiac arrest is the data files that the manufacturers use to both collect the data and then run the post-event analysis to calculate compression fractions and release and all of that is also proprietary. And the problem that causes is, if you're, say, the quality manager or the medical director in a system that has more than one brand of defibrillator monitors in the system, you're trying to combine data from these different proprietary platforms, and that doesn't work well because you don't know if the standards that they're using for how they're defining their compression fractions, et cetera, are necessarily the same. There can be nuances in those algorithms that can introduce some variability in the results, and there's just a whole slew of problems. But I think, there's probably a play here for the professional associations to maybe start with something along the lines of a position paper asking for this. And then, I would then see as maybe a subsequent step is system administrators putting that sort of stuff into their RFPs and saying, this is part of our specification, is it needs to adhere to, this open data source standard that was called for in the position paper. But it's going to need to be incremental. But I think it's going to be that that silent hand of economics that you were referring to before, where the market is going to have to push the suppliers to break out of that. And that's where I think we need to work together as clinicians and administrators and medical directors to try to demand those sorts of changes from our suppliers.
Yeah. So it sounds like you and I agree in philosophy that if you're in the post-event review and you're looking at your analytics, your first shock, your timing of shocks, your CPR fraction time, your peri-shock pauses, you ought to be able to click straight to the patient care record from there. Or if you're in the patient care record, you ought to be able to click over to the analytics, or maybe to the 911 call, and vice versa, as opposed to completely separate systems, completely different passwords, no interconnectivity. They're not linked in any way, shape, or form. That seems to be a huge problem. So while we're all waiting for the middleware solution, one of the things in your video that was interesting is like literally someone in real time clarifying when certain benchmarks were met. Do you think it's realistic or fair to say some tired QA/QI coordinator chained to a desk somewhere is somehow magically responsible for all of this stuff after the fact, buried in their, 6 computer screens and 6 softwares? I mean, realistically, unless their only job is to annotate cardiac arrest, what do we do while we're waiting?
Yeah, and this is where I think we have a bandwidth problem. I'm going to combine this with a different point I brought up in the presentation about the flat file Excel approach, where imagine a single episode of care is one row on an Excel file, and there's a certain number of columns in that row that are for the CAD data. Another set of columns are for the non-transport medical first response agency. Another set of columns for the ambulance. Another set of columns for the emergency department, the acute care specialty team, et cetera, for the entire episode of care. And then the issue is getting perhaps a CSV export from all of those disparate data systems that allows you to drop those data elements into the appropriate columns, so that once you've harvested from those data sources, you now have a single row in your Excel sheet that has the data elements from the different data sources, and then you can run your metrics. The challenge in 2021 is essentially the same challenge that we were running into when I built those sorts of processes in the early 90s, and with subsequent positions I had or consulting engagements, was the manpower issue. And having just the designated QI guy or gal just doesn't have enough horsepower to do it, even if that was their only job. So the solution that I've been proposing is we've got an issue with clinically oriented career ladders in EMS. And so, what I envision is something similar to what the hospitals have done, in that they have clinical nurse specialists. So they have someone who is still working, in direct patient care and nursing, but at a little bit higher level. But they're kind of the designated, expert in their particular niche, whether it's a neuro nurse, trauma nurse. There's several different specialty areas with this in nursing. And they get some additional training and have some additional responsibilities, a lot related to the quality management of those case types. And I would like to see something like that in EMS. So imagine that you've got a group of medics within your agency that are responsible. They take stewardship, if you will, for the cardiac arrests. And they are the ones who will do that data abstraction. They'll run the reports, drop the stuff into Excel, etc. It's a promotional position. So you get promoted in the position, you get some extra training, and you have some extra responsibility. And I think this is something that can be feasible if there's a little bit of time between calls, if they have a lower UHU. Something that I observe in a lot of large systems is there's some stations that are so-called vacation stations, right, where they have a pretty low call volume. And to make better use of those available resources, particularly during business hours, there might be an opportunity to introduce that into their work responsibilities, or there might be some protected time when they're not on the front line to do those sorts of activities. So I think we just need to get creative a little bit in how we can better leverage our workforce and engage them academically as well as clinically to help provide some additional manpower. And kind of a part of that is maybe envision there's a cardiac arrest team, again, consisting mostly of field providers that work together in not only sharing the work of doing this manual data abstraction or running the reports, but also coming up with the QI projects and executing on those projects. Again, it shouldn't be just the QI manager or the medical director. That is the people who come up with the ideas of these things. I'd like to see more of frontline people, but with an expanded scope of responsibility and additional training in a clinical specialty area, be it cardiac arrest or STEMI or trauma, pediatrics, et cetera, to kind of take the charge on this. As this is, kind of what I would love to see happen in our industry.
Yeah, you raise a good point, Mick, and I think this comes out for departments that are accredited, whether it's CAS or CIPSE accreditation, things like that, is if they want to know, for example, in the fire service, they want to know if your entire effective response force or your EFR arrived on scene of a structure fire, let's say within 10 minutes, and you're looking at each unit and how many people were on that unit, and whether altogether it equals, let's say 14, did they arrive within 14 minutes? The line battalion chief is responsible for filling that out before he leaves his 24-hour tour of duty. So when we're eliminating unnecessary steps, so the person that's best positioned to score, like let's say, to take like a soccer analogy versus a football analogy, that the quarterback controls everything versus the person in the best position to score takes the shot. If the 911 telecommunicator knows that they just had a cardiac arrest call, they know that that recording is going to be needed for QI purposes, maybe you just make a copy of that call and upload it to that file right then and there, and eliminate the extra step of harvesting and looking up and logging in. That's all non-value added activity. So are those the types of efficiencies you're talking about? Just like, or someone in real time calling to debrief someone while it's fresh in their mind? It seems like
Yeah.
the more we let the dust settle and start from scratch, the harder it is to reconstruct.
Yeah, the trail goes cold very quickly, and that was one of the advantages of that telephone interview is we weren't even waiting for the charting to happen. Uh, I was just reading an article earlier today about medical charting errors, and they were attributing this to the fact that oftentimes the attending physicians are not doing their charting until days afterwards in big batches, and they get the facts confused or cases conflated, and an awful lot of errors in there. And I think we make ourselves subject to that with charting towards the end of the shift. You've been busy all night, and then you're trying to catch up on your records. We've got to find some ways around that. But there was a comment made in the chat by Jen asking, making the question, if they were all truly linked, would the QI part be legally protected? Or would patients' family lawyers get access to all of this? And this is kind of gets back to the issue of non-discoverability of quality management data. And unfortunately, not every state has explicit inclusion of EMS in those non-discoverability laws. There is some variability there. But the idea is that if you do this under the umbrella of a appropriately sanctioned QI body, whether that's at the EMS level or the hospital level or a combined one, that all of those quality improvement activities and the data that they collect will remain protected. But there are some definite rules that have to be followed by that quality assurance group that's doing that review to maintain that shield of non-discoverability. And it's important to understand what the rationale is for it and why sometimes the patient attorneys push back against it. The intention is to not put up a barrier to healthcare institutions and clinicians to identify errors and find ways to prevent them from happening again and making appropriate corrective actions. Before those sorts of laws were in place, there was actually a very negative incentive for doing quality management because you might find a problem and then it could be just, be discoverable to a plaintiff's attorney and the institution or clinician, suffering the legal consequences of that. And so overall, it seemed to be a net negative for patient care. But obviously, if a patient suffers a bad outcome, the plaintiff's attorneys would like to have discoverability of all that for the purposes of their legal case. So it does have some conflicting things that both have some appropriate interests. But to answer your question more directly, Jen, those activities need to be done behind that firewall, behind that shield of an officially sanctioned quality management program, and certain rules have to be followed. Anything to add to that, Tom?
That is such an important point you just brought up, Mick. And South Carolina is one of those states that doesn't really have the protections for EMS quite as much as they should. There is a statute, but the medical control physician has to be directly involved. It has to be a meeting that was called for that purpose and whatnot. So what we did is we partnered with the Center for Patient Safety, which is a federal PSO or patient safety organization. And when you partner with a PSO, which is very inexpensive, by the way, crazy not to do this if you care about protecting your quality improvement activities from discovery, they help you write your policies and procedures. And so if we were giving feedback to a crew because, let's say, well, who knows, maybe they gave the wrong drug, or maybe they gave the amiodarone, but unbeknownst to them, they already had ROSC. So it wasn't the shockable rhythm they gave the drug to where you're okay, you're having a meeting to decide if a medical error occurred, things like that. You're giving feedback. It would say directly on there, This email is considered patient safety work product according to, and then we just wrote the federal code, and is, protected by the Patient Safety and Quality Improvement Act of 2005. And we'd like stamp it with that, whether it was, our post-event review, whether it was our feedback to crews, etc. We would like literally, now, could they challenge it in court? Sure. But we wanted to show that we were doing sincere quality improvement activities, and stuff that we thought fell under that umbrella, we labeled it that way. And so it's a smart thing to do, especially if you're in a state that doesn't overly protect quality improvement activity. Consider partnering with a patient safety organization. There are not many that deal with EMS systems, but there are a couple.
Yeah, no, great points. The other strategy I've seen some EMS agencies do is they do it in conjunction with the hospital, so they come under their umbrella. The part of the problem you run into, though, is if you interface with multiple hospitals, you may have to have, multiple relationships like that, because it kind of gets a little bit strange if you're talking about a case that was transported to Hospital B under Hospital A's QA program.
Exactly. Exactly. Well, we're at 3 o'clock, Mick. Did you want to think about wrapping things up?
Yeah. So I would like to first of all thank everybody for coming to the webinar. If you weren't able to catch all of it, we'll be posting the archive copy of the presentation with some of the technical glitches. I'll edit out before we put that up, but everyone will get a notice of that, and we will be working towards getting some more of these out again soon. And appreciate the questions and interaction we've had from folks along the way today. Thanks so much for that. There's going to be more information with all of the recordings for this entire webinar series is at acc.org eReports EMS, along with mention of other products and services that the ACC is rolling out for us. For more information about CSI's products, you can check out emsqualityacademy.com, emspurchasing.com, etc. Thanks again to Tom. Sorry Tim wasn't able to join us this time. If you do want to reach Tim, you can reach him at ecgsolutions.com, and there's his email there. And Tom's new digits, tbouthillet@gmail.com, still has his same Twitter address, LinkedIn addresses. So on behalf of the American College of Cardiology and the Center for Systems Improvement, appreciate you all being here for today's presentation, and that'll wrap it up. I'll meet you in the lounge here in just a few minutes.
Thanks, everybody.